it engages well. Next. So we pulled out the left catheter, the right catheter out, and went with the guiding catheter through from the right groin. Now we have a wire we decided to do the LED diagonal first and another micro catheter.
So
yeah, go ahead.
Can you give us a little bit of an idea how you approach this CTO, what your thought process is, and what your plan will be going into it?
Okay. This CTO, we have no idea how long it has been a CTO. We have no history prior, no EC changes, anything documented. So we expect this to be a old lesion, especially with the retrograde collaterals like this. The diagonal is very close to the origin of the at the total occlusion, so we have to protect the diagonal. Anyway, diagonal probably will need to be treated also. So we have a wire there and got that microcatheter, this thermo microcatheter and the BMW wire, and position the microcatheter close to the lesion, and I've only got a BMW wire. We didn't proceed any further. And I intend to see whether this wire will cross.
Of antegrade wires first to see if you could cross.
Absolutely.
Okay.
Absolutely.
Do you always go first with the BMW wire, the workhorse wire, knowing that it's a CTO, long duration,
generally,
possibly
I
hard
do that,
lesion?
especially when you have got a proximal, and proximal vessel is disease-free. I would like to do everything to protect that before I bring in a stiffer wire if I have to. Small test.
Can you comment also on your choice of microcatheter here?
We have used which one? Microcatheter? We have used a fine cross. Okay. We have other choices. I've tried. This is the standard microcatheter which we generally use. Only now the Asahi is available. I don't think there is much difference between all these microcatheters except Asahi tip is the 2.6. I have never used it. Okay, we are stuck. Wire doesn't move too much. I have just left it there. We'll take a picture and before we change our strategy. Take. Okay.
It has moved a bit.
Yeah. Is there any retrograde filling of the LED that you can see, or not much?
There is, but not much.
Yeah.
Can you go to the LAO? I want to cannulate it better. Test. Test. Okay. Come to RAO and epicrania. Okay, we'll take a picture. It is filling all right, but the gap is very, very long.
It's a long segment.
Yeah, it's a long segment.
Yeah, very long segment.
Yeah, our approach here
So,
would be to take a Miracle Brother wire here and feel that for a short period of time before switching to a polymer jacketed wire like a Pilot 200. But I would try a Miracle 6, 3 or 6, and just see where that goes.
Okay. How about Gaia?
Are you planning to use Gaia? Yeah.
Gaia's a great wire
Yeah.
too.
No, I'm just asking your opinion.
No, I think Gaia's the issue with the Gaia is that you're not going to get that much tactile feedback. But I think it's a lovely wire. Clearly, I think you could start with a 1, but you really will need a 2 here. My concern is you don't
Okay,
have any
I don't know, Gaia has not worked too well with me. I think there is some problem between me and Gaia.
So basically you should be
I still
using
go
the
on to
wires you
my,
are familiar with and where you get a good tactile sensation
that's right.
and also, you know,
My first choice wire for any long CTOs is still the Conquest Pro 12. I don't know. Somehow we got used to it for a long time. I don't upgrade my wire from 3 or 6 to 12. I don't do that. I go straight for the nice feel about that wire behaving in my hands.
so is that the wire you're using now?
Yeah, I've got a Conquest Pro 12. Small.
So again, this is a very
See, the
jacketed,
tip
stiff
of the
wire.
microcatheter is against the lesion. So I would prefer to keep that away from the blunt lesion, because our control on the wire tip will go down if the microcatheter is too close. Small test.
You made some good progress.
I just tried to see whether the wire can find a way without much difficulty, and making sure the tip moves all the time.
Yeah, this is a very stiff polymer jacketed wire.
Can you give me an RCA injection? Reduce the cranial. Okay. Reduce the cranial. Okay, go ahead.
Inject.
Oh. Picture. I'll take a picture and then look at it in another angle.
Yeah, absolutely, to make sure that you're dancing in the architecture.
Before I puncture the distal cap, I want to be sure. Can you come to an RAO? Okay. Picture again. Flap.
And it's important, as Dr. Matthews is doing, to do orthogonal views and change the angle so that you know you're not offline.
Go to LA Accorda.
Looks like there's another diagonal there.
No, that's not too good. LA cranial. Not too bad. Okay. Picture.
Dr. Matthew, this is Dr. Munawar here. So what kind of wire that you use?
Epicrane. This is a Conquest Pro 12.
Or Conquest Pro?
It's a very stiff wire and it's a tapered tip, polymer jacketed. So you have to be
basically you
extremely
escalating
cautious.
wire just from the BMW and then directly to Conquest Pro?
reduce the gradient? Yeah, little higher. That's right. Can you give me 2 minutes? I just want to, this is very crucial position.
So you're at the distal cap, but looks subintimal.
Okay. Once again, picture.
I take another picture, Dr. Matthew.
What the cytophil?
So what I would do here is swap this out.
RAF.
Fine cross down.
Okay. Picture.
Matt
Table.
is calling.
Side to side, up and down, close. Okay.
It's fantastic. Wow. It's Boston wire.
Yeah.
Looks like
Okay,
you're in the
take a picture.
distal bed.
One more. I think we are on the right track. Let us check it out.
My approach, Dr. Samuel, at the distal cap would have been to take the fine
think so.
cross down and switch out to a little bit of a softer wire.
Yeah, I'll do that. How did- Okay, stay there. Let me see whether micro show me properly, Janti. Microcatheter, I can advance it further.
So, Dr. Matthew, whenever you cross and you are comfortable with working, we can even switch to Dr. Saito if you are going to do that. We have about 25 minutes of transition time.
I mean, see, Dr. Saito is to start after I finish because
Okay, no problem.
Okay, then there's no issue.
that's how the timing given to us. I'm just allowing the microcatheter to take time to go across because sometimes if you are in a hurry, it doesn't move in because it takes always the transition takes time.
Very good point.
What would be your approach here if you're having difficulty with a microcatheter? Would you switch to from a push catheter to a torque catheter, or maybe use laser or some other tool?
If I have difficulty, most of the time a 1.25, 1.5 balloon will cross and get some dilatation, then come back and use the microcatheter to exchange. Usually it should not give us a problem. Otherwise, tonus could help us or any other device. Any suggestions from your end? See, we are not used to many of these devices other than the standard ones which we use generally.
Yeah, the
I want to
fine-
check whether I am in right position, whether I am ready to change my wire.
So you've moved your
I
fine
think
cross
so because
distally
the
nicely.
microcatheter seems to be quite in. Okay, I'll take this wire out. Give me an All-Star wire. Oh no, give me a BMW wire. I'm comfortable. So now the job of the right is over. I don't need the right catheter anymore. Now coming back to Munawar's question, why I stepped up from BMW straight to Conquest Pro 12. I don't know, it's maybe a force of habit. When I try to get across into the total occlusion, I want first try wire to be the best wire of mine. So I keep repeat the same process all time and again, and sort of it worked well with me.
Yeah, you've become very good with that wire, and clearly you have a master expertise. But I think for a new operator, I would not recommend going from a BMW to a Conquest Pro 12. It's like going...
Correct. I 100% agree with your... Go ahead. 810.
So the fine cross is out, and now you're going to start ballooning.
Little more. Some more. No. Go up.
And how is our patient doing, Dr. Matthews?
Okay. Patient is absolutely fine. How are you, Satyaraj? You're okay? Okay, he's fine. Okay, give me a 2 millimeter balloon, a non-NC. So now that the microcatheter has crossed, the lumen should be good enough to accommodate a 2 millimeter balloon, a mosaic, the compliant mosaic. Not, no, give me a new one. 215. I generally use a compliant.
No, I said you're taking a non-compliant
Yeah, non-inflated balloon
because
because
lower profile.
Absolutely. I mean, sometimes you may get away with a non-compliant balloon also, but here we have the liberty of using whatever the best works with you. Mosaic, the compliant balloon profile is excellent, and you saw the tapered stent. Not many companies do the tapered stent these days, and it works very well. Biomime tapered ones. Epicranial. Negative. Crossing without much difficulty, we'll go ahead and dilate from here. This we had a documentation that it was not filling. Go ahead. 10. Oh, it opened up at very low atmosphere itself. Negative. Okay, go up. Save. Negative.
So we're having a little bit of a
Technical issue.
but we are imagining that you're continuing to dilate that segment. And then my
That's
question
right.
is...
It's dilating at 10 atmospheres, 8 atmospheres.
In your CTOs, Dr. Matthews, are you using imaging like IVUS in India, or are you just then proceeding with stenting based on the need?
Oh, no. We use IVUS, yes.
Yeah.
We are going to use that to decide the stent size, the length. Go up. 3, 4. 3, 4. Negative. 3, 4. Have you resolved the technical problem? Are you able to
Yes.
see
It is
it?
better now.
Negative. The balloon moves quite freely, but let us take a picture. Okay. Now,
Well, you have a lumen.
what is the suggestion? We have half an hour left for this transmission. Small test.
Would you like to go with the bigger balloon now or do an IVUS or?
I think we'll do an IVUS. Vijay, what do you think?
Yes, I will do an IVUS.
Okay, get the IVUS ready, please. We'll go with an IVUS. Let us assess what we want to do. I'm taking out the right catheter. We don't need it anymore.
Agreed, yeah.
That will be less things on my table. Now, again, back to the choice of what is, standard teaching, we know you step it up slowly when you change wire, upgrading it slowly. What is the choice of wires all of you have? All of you are very experienced operators. What is your most favorite throttle occlusion wire?
Yes, Dr. Munawar. Choice of wires.
Vijay, you want
if
to
you were doing the
wash up?
case.
Yes, sir.
Choice of wires if you were doing the case.
Yes. If I do the case CTO like this, I mean that we are CTO this one. Yes, and my daily practice is actually just bring down the microcatheter to as close as possible to the approximate cap. And then we start, usually with that kind of wire, we use soft wire, any soft wire. And then what we want to do is usually to start with the filter XT first. Then then we escalating with it's dependent. If more calcified, we direct to go to the Gaia second or Gaia third, but if not, then we Gaia first. Then, if still stuck, then we are using a very stiff wire like Concast Pro 12. And usually we are doing step down, but sometimes step up, sometimes step down. So if we see there is a tiny channel, go with step down with back to XT, then until across. The problem, I know that in the past we do like Dr. Samuel Matthew, but I mean that, but I know that it's very skillful, Dr. Samuel, because doing with very stiff wire, sometimes tactile sensation is very important. When across and if they go to the it should know there's some resistance if we pull it back again, then go in, and finally we can go like Dr. Samuel. It's an excellent demonstration of Dr. Samuel.
Yes, Dr. Matthews, we're with you.
Who was speaking just now?
Dr. Munawar.
Hold this, please.
Dr. Munawar was speaking.
As you rightly said, absolutely I agree with you. But over the last so many years, we graduated to using these wires, but that doesn't mean that what I did is right. I would definitely agree with what Munawar said, it should be the standard teaching, and especially if your experience with these wires are not very, very high. You cannot take any kind of liberties, because once you make a mistake, you are done for the day. That,
Yeah.
okay.
Image on.
Can you show the IBIS image, please, there?
So we're having some technical difficulties again, Dr. Matthews, so you can maybe describe what you see on the IBIS?
Okay, go ahead, Vijay.
Yeah. We are in the distal LED now. The LED is around 2 millimeter size, a grossly underfilled vessel. Record. And you can see lot of block from 9 o'clock to 3 o'clock position. Yeah, we are just starting the pullback. And it's a diffusely diseased vessel and grossly underfilled, so it looks very small.
Yes.
Yes, we're back, yes.
You can just see a branch. Yeah, we could see a branch joining there. And a 3-layer architecture, well maintained here. So we are still in the true human.
So
Yeah, it's a bigger. There's a
Do you get a sense that you fenestrated and came
And
back
all
in,
looked
or
soft
true to true
and,
all the way?
No, I think it looks all the way true and true. And still we are in true human. I think we are just coming close to the proximal. And vessel is bigger here, 3 millimeter.
This is distal to the
Yeah, it is a lot of plaque, a little bit of calcium. Calcium is on the adventitious side. And now it is an intimal calcium. The vessel is much bigger.
yeah, you're approaching the proximal cap now.
One. You can see another branch, the diagonal branch is getting
Here's that
connected here. You can
diagonal.
see the wire. And vessel is very big here, 3.5 to 4 millimeter.
So you have to stent all the way from the diag down.
Yeah, we have to stand from all the way down. And we have to just to see the distal landing zone. Maybe this doesn't appear to be a disease-free zone, and we have to do a small size stent and approximately blow it up.
So I think this is a very great learning point in CTO-PCI. Dr. Matthews has made this look very easy, as he is a very experienced operator. But the imaging component, taking the
Just give
5
distal,
minutes
that's our size.
to appropriately do the imaging,
And length
getting the
from the
landmarks
diagonal.
and the size, is really the only way you're going to have a
Okay, Manish, now that before that, we will the ostium of the LED and the ostium of the diagonal doesn't seem to be very
Very much
diseased.
diseased from IVUS.
In IBIS also it looks okay. So we will not stent the diagonal ostium. We just want to recheck whether we need to stent the diagonal at all. There is some mid-disease. It appears now around 50-60%. We will do one more check and then let us take a decision on that. I'll take the cine now. Show the cine, please. Proximal segment is diseased.
Yeah.
Okay. What we'll do is before we go ahead and stent across the diagonal, we are going to do the diagonal first and
treat the diagonal.
away from the ostium and then stent the LED from right across the diagonal. 2 mm NC balloon, please.
What's the length of the LED lesion you're going to stent, Dr. Matthew? It looks very long.
Looks.
Just doing the measurements, please. Give us 2 minutes.
Yeah, just no, go to long view. Yeah, LED. Just go to the long view.
Dr. Vijay Kumar is our expert on all imaging, and he runs our core lab also.
Done. Go to long view.
Manish, for your information, we have a excellent core lab. Just for research purposes, we have established very well. We have been regularly doing analysis, both coronary, IVUS, OCT, all. Now we are upgrading it for the structural heart also.
Congratulations.
That's very good.
Yeah.
It's very, very
It is located now at Madras Medical Mission, but it is independent of all institution. It is purely our own investment.
So what will you
But
be putting in the
if you
diet?
go with a disease and IVUS, it looks like you have to stent to the distal LED. I think maybe we can just find a zone beyond the lesion, maybe a reasonable place with a less than 50% plaque burden. Maybe we can end up with a 28 or 30.
Little longer because I could feel that lesion was not giving me a distally test.
The problem here is a disease throughout. It is not the disease-free, it is underfilled vessel, and you could see the plaque everywhere.
Okay, go up.
This is a perfect case for a tapered
What do you
byline.
all say? Dr. Saito was sitting here. What is his opinion?
Just you can.
Saito, you saw that disease. You saw the IVUS picture. I mean, what do you think? What should we do?
Maybe I want to place a stent in the initial region.
For the LED also? Okay, Upender, Dr. Saito feels that he would not put a very long stent. He will treat only that proximal across the diagonal and maybe 20-30 millimeters or?
How much?
So what do you all feel?
Well, it's a difficult
disease,
decision, but I think you
to
can.
save.
Just find from diagonal you go down. Diagonal you go down and find a place with a less than 50% plaque burden. That's okay. Just go down.
As per the
find
IVUS, there
place
is
with less
a
than
lot
50%
of
plaque
disease
burden,
and
so you can
Okay.
just in that area.
narrowing.
That's right.
It's,
Now,
it's
if we had to
tempting
go
treat
for
the whole
surgery, what
segment.
would the surgeon have done?
Yeah, and in this case, I mean, it's not like surgery is in the future, so I think that as long as you have good outflow and are matched, you should be okay, but that's a difficult decision.
Okay.
கீழ ஒண்ணும் பெருசா dissection
Okay,
இல்ல.
give me a 2.25 stent. What is the long stent you have? And for the LED? Okay, the tapered stent privileges only we Indians have. Japan, they have not used the
Dissection
tapered
இருக்கு.
stent. That's what.
அது we just see எங்க இருக்கு.
How many of you are familiar with the tapered stents?
Well, I think
இல்லடா.
I use it quite often.
இது எல்லாமே dissection.
We don't have the luxury of having it, but we would
Yeah,
love
we
to
are
have it.
comfortable.
Just
Yeah,
cut
it makes sense.
ஒரு 20-30
Yeah.
எடுத்துட்டு அதுக்கப்புறம் ஐவஸ் பார்க்கலாம் எப்படி
The tapering vessel of-
புட்ட ஷார்ட் ஸ்டெண்ட் தான் இல்லைன்னு வச்சுக்குவேன் 60
As
70
it
millimeter
branches,
So,
the
which
vessel
one,
goes on becoming
2.53 we take?
yes sir 2.53 or 225
I want the stents, please.
Comes in the sizes, I think 2.75, 3 and 3.5, and tapers by 5.5 millimeters.
And the lengths?
Lengths are 30,
Yeah,
40,
0.5
50 and
millimeters.
60.
Wow.
diagonal.
Oh, 60 we have.
Up to 60. 60 is the longest.
That's wonderful.
price is a little more, but then, much less than 2 stents.
Yeah.
Sorry, we. What is the length? No, give me 2.25 stand.
2.25 doesn't come in tapered.
It's for the diag.
No, 2.25 comes in tapered. The one we used for the RCA was 2.75 to 2.25.
Oh, I see. So he's using a taper 2.75 to 2.5.
29.
That's kind of cool.
0.75.
We have another 5 minutes, 7 minutes to go.
I would love to see you put these stents in.
Okay. I hope will be 3 to tapered. What is the size here?
3 will taper to 2.75.
How much is 275? How much it goes up? Another 0.2. Because proximally we need a bigger.
Okay, I think I will. I'll take after this picture.
So you're going to be treating the diagonal first
Yeah,
after
that's okay.
Matthew, correct?
Yeah. Yes, please. Okay. Show position the table.
Yeah, it also makes sense that, you're going to put in a stent in LED and then
Jailing
you'll be
it.
worried
Yeah.
if the ostium of the diagonal is covered and then you have to do a lot of tricks to get in.
Yeah. A little bit of work to get in. Looks good.
Picture. I have to come back till that side
Yeah.
branch. Test.
Do you have any specific tips on inflation pressure or duration when you're using
Okay,
a
go on.
tapered stent?
Well, unlike the other biomime products which usually
8.
expand from the center and go,
7, 8,
this doesn't. This usually
9,
starts
10.
from proximal to distal,
12, 13.
as you can see here.
You see this, I hate somebody preparing the balloon and stents like this. They have not taken the proper negative suction. Negative. It's terrible. Then you do not know whether the stent is expanded.
Yeah.
The standard protocol for stent
Expand it.
preparation and balloon. But this
No, he's
okay, that side branch was disease free, at least it was retrograde filling up to there. This is 45. I will take a 60 tapered stent.
Okay, yes.
We all agree.
Okay, give me a 60 please.
60.
I have decided, looking at the IVUS, Vijay also is little concerned about using a 2.5 stent in a high pressure situation. So he prefers to have the distal part of the stent at least 2.5 and deploy it at high pressure so that it will become 2.5. And 2.75 can be post-dilated to 3.25 at least.
Okay.
Yeah.
60,
So,
3 into
so
2.25.
that is our decision now.
No. 60, 3 into 2.5. 3
Okay, we have
60,
few more minutes in our
2.75
transmission.
into,
3 into 2.5. So 3 into 2.5, 60.
you don't have 2.75 into 2.25. Give it fast, please. We have only 5 minutes.
Yeah, exactly. Yeah. Okay. So you, after this, we'll have you go right up.
2.25.
7.5. Oh.
Two,
I mean-
2 millimeter, 2.
It's the ideal case to decide using a tapered stent rather than two overlapping stents, and we have the documentation with IVUS negative properly. I mean, there is a general tendency of not preparing the stent balloon properly because they feel if you go on negative, the stent becomes loose on the balloon. I don't think that will happen at all because these stent technologies are so well
Absolutely
done now.
right.
You
Absolutely
don't,
right.
the stent, even if you want to move, it doesn't move.
It's absolutely correct. They're very well crimped.
So
and-
you can safely do it and prepare the balloon properly. You can go negative into the vessel. You saw that the calcium on the IVUS?
Yes, we saw.
Absolutely.
It wasn't circumferential, but it was there.
So
yes.
we will have little difficulty here.
Getting in.
So we will be very careful in advancing now. Sometimes it may not, it will get caught in that calcium even though we have prepared the lesion well. Especially this is a long stent. As I said, slowly you have to allow the stent to move in like the microcatheter. Don't be in a hurry. Keep watching the guiding catheter.
There you go. Almost there.
Take the picture. Yeah. We are fine. Go ahead. 6, 7.
7,
8, 9,
8, 9.
10, 12. Give me a 3 NC balloon, please. 13.
You can see the taper.
Yeah. Can really appreciate that.
Yeah.
Negative. And as we used to teach in olden days, still it matters. When we are withdrawing balloon from the long stance, make sure the guiding is disengaged. When you, otherwise you can drag the guiding in and dissect the ostium. Take a picture.
That's a very good point.
Okay. I'm taking that balloon, I don't know whether it will cross the lesion again. Go to 1 atmosphere. The transition from the stent to the normal vessel, I just want to have the balloon there for maybe a couple of minutes. It generally helps to mold that area better. a very low atmosphere, 1 to 1.5 millimeter atmosphere pressure. Sorry, negative. I just went up a little there.
Clearly, the proximal vessel will need to be post-dilated aggressively, and you'll have to rewire the diagonal.
Correct.
I think this has been a beautiful demonstration of a complex
The
case.
diagonal wire is moving very inside. That
Yeah.
means the proximal part of the stent is definitely under deployed.
Yes.
3.
3 into 8 or 3 into 15?
15.
15.
Whether we should wire the diagonal now or not.
Yeah, I mean, I think in my lab I would, just so that we don't. I mean, not that there's going to be a problem removing it, but this way you can do your post-dilatation and pot technique and finish with an IVUS. What we're going to do is take this opportunity to thank you and come back to you,
Balloon.
and we're going to go to a lecture. Can we take one cine and see the whole LAD before we depart?
Yeah, I'll give it to you. Give me 1 minute. I'll just put this balloon into the guiding and then give you the cine.
Holding the wire.
Okay. Can you stay ready for the cine? Yes. Okay.
One sec, please. Contrast.
Just giving you the injection. Did he have any complaints? சத்யராஜ் மூச்சு இழுத்து பிடிங்க. Hold your breath.
Very nice case,
It
Dr.
looks
Nathan.
good. What we'll do is we'll let you all go. We will just post-dilate the proximal segment, and I may not cross into the diagonal because I don't think there is any need to have a kissing balloon for all the stents which has got a
Agree. Yeah, it
across
looks very
the
good.
side branch. Especially this case, I will not do it because I don't have an proximal stent on the post-dilate there. I mean, dilate it well. Result, and that should be the case should be
Some
done.
nitroglycerin injection and then.
Fantastic.
see the distal
Thank
vessel.
you.
Yeah.
Beautiful case.
That's right. That's right. Thank you so much. Thank you, Manish. Thank you, Munawar, Upender, of course. Thank you for having us live.
We will see
Now
you in a
you can
in a
see
half
the
an hour.
hero in action. Dr. Saito will come in
Very good. Okay.
half an hour.
Wonderful. Thank you. So with that, we're going to have Dr. Call present
Bye.
his lecture on his experience with biomime morph in long lesions and diffuse disease. Dr. Call, thank you very much.
Go.
How much?
Thank you very much.
13.
I must thank Merrill Life Sciences to
13.
Negative.
வினோத் எடுத்துறீங்களா
Now, we all know that
Eight,
the coronary arteries taper, especially the LAD circumflex. Most branching coronary arteries taper by at least 0.5 millimeters if they are more than 20 millimeters in length. And this significant tapering usually poses a problem for optimal balloon sizing. Of the vessels also poses a problem if you go with the balloon with the reference diameter of the proximal, it may be too big for the distal and can produce a dissection. At the same time, proximal portion dilated. So that's how the concept of tapering balloon, which maintains the balloon to artery ratio. Actually, this concept is not a new concept. If I remember correctly, Bar used to have a balloon, and Dr. Vidya Banka had made a tapering balloon. So this is an old concept, and which has been brought here very elegantly. And basically, it is the balloon which is tapered, which makes the stent taper. It's not the stent which is tapered. Ultimately, the stent gets tapered because the balloon on which it is mounted is tapered. So the current clinical practice in many such lesions for many years were more so the tapered stents are designed to deploy across single long length stenosed lesion so that there's a conformability of the vessel, homogeneous radial force, mechanical stress, and stent arterial ratio, which is along the stented segment, remains correct. So this is the biomime morph, which basically has sirolimus as the drug, and it has this stent architecture which is well known for all the biomime stents. It has, the closed cell design at the edges and an open cell design which permits very easy recrossability through the struts in the middle. So this is the stent design, and the side branch access is easy, and you can expand a 3 millimeter stent and go through the struts and go up to even 3.5 without distorting the stent. Drug is sirolimus, and you all know sirolimus is one of the very effective drugs to prevent neointimal hyperplasia and reduce restenosis. And also the polymer here is a bioabsorbable polymer, which is PLLA, and this is a Merrill's property biodegradable polymer which gets degraded in a 2 to 3 months time. It is uniformly distributed over the stent, and now I'll go to some case examples. Actually, we are in the process of doing a 300 patient registry for morph stent, and also are planning a randomized study between single stent and overlap stents, and then see really does it make a difference in terms of long-term results. Can we get into the first case? Yes. Okay, this is a 32 young man who presented with features of acute coronary syndrome, and left ventricular descending is filling. So it's a total occlusion. You can see that, although the history is very short. And you can see that total occlusion and abrupt occlusion of the left ventricular descending. Fortunately, the collaterals were there, so there was no complete infarction, and the LV function was normal. Now, this is the PTCA process. This is the guiding catheter, and you can see the guiding catheter short and trying to go through the lesion, the LAD, and the lateral view very clearly tells you that this is a diagonal, not the LAD. At this stage, we have taken a right shot, and you can see the wire, which is the Fielder XT wire, very close to the occlusion, and finally crosses it.
Get that wire out of there as soon as I can.
At this stage, we changed the guide wire to a BMW wire because Fielder XT was not very comfortable with, because of its polymer and very tip which is very sharp. So we're pre-dilating it, making the bed prepared for a stent. Pre-dilating, and as you can see, after pre-dilatation, I think this picture will show you the vessel. Yeah. Now you can see it's clearly a tapering vessel, and I think a very good case for using a long tapering stent. So we've taken a biomime morph, 60 millimeters in length, 3.5 millimeters proximally and 3 millimeters distally, and you can see the positioning, the expansion.
Got a dissection in the diagonal.
Next, yes. And as is necessary in all these long stents, we need post dilatation very effectively with high pressure balloons. This is 3.5 millimeter balloon in the proximal part. And I think that is the ultimate result. And you can see the tapering. You can very clearly see that the stent is conforming to the morphology of the vessel, which is tapering, obviously. Okay, one more case. Can we go to case number 2? Any problems there? Okay.
Let's start the second session with a live case. Yeah, so we give a break and start at 11.
Okay, this is a 53-year-old gentleman, diabetic with multiple risk factors, who had bypass surgery in the past. And this is case number 3 actually. Right was patent, others were occluded. And you can see this patient had his angioplasty first many years ago, followed by bypass surgery, and you can see the LAD has a stent which has significant instant restenosis, and the circumflex obtuse marginals have got disease. So dilating it, we used a cutting balloon. Prepared the bed. Once again, you can see it's a very long segment of disease. Tapering vessel, proximally big and distally not so big. So once again, we have taken a morph 3.5, which tapers to 3, 60 millimeters length.
You gotta love it. One stent, you're done.
Post-dilating it. So you can see the vessel which is tapered, and the stent is really confirming. Then we have wired these two vessels, pre-dilated, both the vessels.
It's too expensive.
And now here we're using V-stenting using Biomime Aura, which is again is not a tapered stent because we don't think it needs a tapering. And by the V-stent technique, both have been deployed simultaneously, both dilated, and this is the final picture. So complete revascularization. The RCA graft was patent. The final picture. We have time for one more case?
Yeah, sure.
Okay. Actually the case 2. This was case 3. This patient, I think, has triple vessel disease with right coronary artery, which was, borderline kind of a lesion, and significant disease of the LAD. Circumflex was a near total occlusion. Okay. Well, this is a 48-year gentleman. And you can see this circumflex, which is, sub. And you can see the long segment of left ventricular descending disease, just distal to the septal. This is the right. We did an FFR of the right, which was showed a normal flow 0.88. So proceeding with the circumflex lesion, trying to cross it again using the Fielder XT. Having some difficulty in crossing there. See, it has gone in, but gone into a very small posterior branch. Keeping the wire there, we gone with BMW wire and went into the major branch, which was the target. And once again, you can see that the proximal vessel is significantly bigger, larger than the distal target. again calling for a stent which has, tapering. And this is the biomime morph, and as you can see, it tracks quite well after we have prepared the lesion. Again 3.5 proximally and 3 distally, 60 millimeters length. Next, yeah. Positioning it. And as I said, that it inflates proximal to distal. Post dilating.
Beautiful.
Wired the LED now. Pre-dilated. Taking a morph, but then there is a problem, long stents always don't track predictably. Then go change the wire to an extra support wire, again dilated that segment which was posing the problem. Dilatation, and now the morph goes in, and once again you see that is a long lesion, long stent, 3.5 tapering to 3, same one, 60 millimeters, which is the longest stent. And as you know that the longest stents available otherwise are 48 millimeters, but lesions which can't be covered by that, this is an ideal solution, and mostly such long lesions taper. So that is the LED now. Always necessary to post dilate. Usually in our day-to-day practice we don't do an IVUS unless there is a in left mains or some situations where you find that angiography alone is not enough. Okay, so there's this patient we did an IVUS at the end. OCT at the end, as you can see, the proximal, mid segment and the distal very well opposed all the way through. Can I come to the last slide? I think 3 cases are enough.
Main presentation.
Yes, main presentation. Yes. Come to the end. No. Okay. So we'd like to conclude that long diffuse lesions can be better treated with single long stents to minimize the risk of fracture. Hopefully it reduces restenosis and associated adverse events. Our randomized trial between overlapping stents and single stent, I think, is going to be this trial which can give this answer. Long stents are also convenient from procedural perspective, as is very clear. Reduces the cost because one stent is always cheaper than 2 stents, and simultaneously the branching coronary arteries tend to taper anatomically, and this design leads to a better conformability without altering the vessel anatomy. And also you reduce the amount of time, reduce the amount of contrast used because you're using only one stent. So long balloon should be an integral part of the treatment, considering long diffuse lesions are seen frequently in our setting. Single tapering stent is a good solution. Tapering design takes into consideration the distal tapering up to 0.5 millimeters. As I already told you that multiple stents are associated with higher restenosis and cost. Single stent with tapering also reduces chances of fracture while upsizing the proximal portion. And single long stent also reduces contrast load, fluoroscopy time, and procedure time, which is always additional benefit. Thank you very much.
Incredible additive tool. I'm actually very jealous we don't have it in the United States. So let's take a 15-minute break, tea and coffee. There's a lot of sleepy people in the room for jet lag. And then we're going to come back and do our CTO session. Thank you. I kind of put the curriculum together, and the first time was a disaster. Actually, a disaster. We had so many problems with AV and this and that. We've gotten a whole lot better. But then Sanjeev was
Hello?
Okay, we're going to get started again for the second session this morning, which is dedicated to CTO PCI, which has become now an incredibly important and part of the globe. And I have the pleasure of introducing Dr. Collins from Latvia, who's here to talk about the current update of coronary CTO. And after his talk, we'll go to back to Madras. Dr. Saito will be performing a CTO. Dr. Collins. Late last night, midnight.
Dear chairmen, dear colleagues, my name is Artis Kalniņš. I'm from Riga, Latvia. At first, I would like to say thank you for organizers for invitation. It's an honor for me to be here and tell you about my experience. The title of my presentation is Current Update of Coronary CTO. According definition, CTO is obstruction of native coronary artery with no luminal continuity, TIMI flow of evidence, or the high possibility of occlusion length more than 3 months. Definition is TIMI flow of 0 and length more than 3 months. We must keep in mind that because in some registries, some trials, we can find different definitions. But if occlusion is not 3 months long, it is not real CTO. Is it problem in the interventional cardiology? Definitely yes. If we look on data from different registries, which was done during last 20 years, we can see that prevalence of CTO is really high. It between 12 and 50% among patients with suspected coronary artery disease. It's near 20%. Among patients with lesions more than 50%, it is more than 30%, but among patients with significant coronary disease lesions, more than 70%, more than half of them have at least one CTO. If we look theoretically, With opening CTO, doing revascularization, we should reduce symptoms, we should improve long-term survival, we should improve left ventricle function, should increase tolerance of future coronary occlusion events, should reduce nitrate usage, and should reduce risk of arrhythmias. But if you look on registries, we can see that interventional cardiologists' activity in CTO cases is still very low. If we compare CTO with non-CTO lesions, most of CTO patients are going to cardiac surgery or are treated only with medical treatment. What guidelines says about CTOs? Last European revascularization guidelines was published in 2014, and if we look on first A class indications for revascularization, theoretically it's first A class indication for revascularization. If a patient have ischemia more than 10%, also it is first class indication for revascularization. And any CTO problem we can put theoretically under first class indication for revascularization. But despite that, if you look what the guidelines says about CTOs, we can see the class of recommendation is not so high. It's only 2A class level B indication. Why is that? Main reason is relative paucity of data. Till now, we don't have prospective randomized trials properly powered for hard clinical endpoints, comparing contemporary optimal medical therapy with contemporary state-of-art CTO recanalization. In year 2000, EuroCTO Club was started CTO trial. Trial is finished now. First data will be announced in TCT Congress this year. And our EuroCTO Club community are waiting results for this trial. We hope that this trial will help us to change guidelines. Symptomatic patients with at least one CTO, 2/3 of them was treated with PCI plus optimal medical treatment, and 1/3 was left only on medical treatment. And 1 year follow-up result will be announced this year in TCT Congress. One other significant trial about CTO is Explorer trial. First data of this trial was published in last TCT Congress. This is trial. In this trial was included patients with STEMI who also had at least one CTO. Of course, all patients was treated with PCI for acute occlusion. And after that, for half of them was done CTO within 7 days, and the other half was left on medical treatment. And last year was published 4 months follow-up data, and what was found? Was found that CTO PCI within 1 week after emergency PCI is feasible and safe, but was not found difference in ejection fraction, except a group of LAD CTO. If a patient had ST elevation infarction in left circumflex or right territory, and after that was open, significant better results after LAD occlusion opening. Somebody can say that this result is nothing. I can't agree with that. I think that the results is very promising. In this TCT Congress will be published 1 year follow-up data in other groups too. Why I can say that? Because now we have more and more evidence about significance, about importance of complete revascularization. This is interesting slide. This is data from Scandinavian stable coronary artery disease patients registry. More than 23,000 patients during 5 years. And we clearly see that patients who received complete revascularization. This slide is meta-analysis about 35 studies, complete versus incomplete revascularization. And also we clearly see that patients with complete revascularization have much better long-term result. And what is interesting in this meta-analysis, that in this meta-analysis was included also patients after cabbage surgery revascularization, and it doesn't matter how we are doing full revascularization with stenting or with cardiac surgery. If patients have complete revascularizations, all these patients have much better results. Mortality benefit did not vary with the definition of complete revascularization. Some years ago, very promising was Syntax trial. Most of you know this trial. A lot of patients, we can see that number of occlusion in this trial was really high. In some group it was more than 50%. But if we look on results, we can see that Syntax trial is not a trial about CTO. Because if you look on PCI group, only 49% of patients was successfully treated. And it's not surprise because investigators on this trial was not CTO operators. If you look on cabbage group in Syntax trial, results are better, but also we see that only 68% of CTO patients was open, 32% in cabbage group. That means that Syntax is not a trial about CTO. And also it is not surprise, all we know that this trial finished in 2000 different. Overall success rate was relatively and 70%. If you look on data from ongoing CTO, Euro-CTO Club CTO registry, we can see that today success rate is near 90%. Some words about techniques. If you look theoretically, CTO PCI goal is restore vessel continuity and flow. It means we need to connect 2 points. And we can do it by antegrade approach. We can use for it a retrograde approach, and we can use both approaches together. And it really doesn't matter which approach we are using, because the goal is the same. Retrograde approach initially was used after filed antegrade approach, but now retrograde approach is initial strategy in many complex cases. In cases with proximal anatomic ambiguity, ostial occlusions, long occlusions, when distal cup is at bifurcation, when distal vessels are very small, and when vessel is very tortuous. All techniques we can divide in antegrade and retrograde techniques, and one relatively new group of techniques is dissection re-entry. Many years ago, by Japanese operators, was discovered success and failure, and many of them are occlusion lengths, calcium, tortuosity, and occlusion stump. And if we calculate some of these risk factors, we can estimate difficulty of CTO. All CTO operators know this GTO score. If GTO score is 0, it is simple CTO lesion. Maximal points is 5. If patient have more than 3 points, it is difficult lesion. This grading is very easy for difficulty estimation, but this grading doesn't tell us which technique is better for this patient. In 2011, in North America, was discovered a hybrid algorithm, and the main idea was to combine complexity and try to tell ancient. And this hybrid algorithm combines all kinds of techniques. According this algorithm, we need to estimate 4 characteristics. It's proximal cap, distal cap, collaterals, and lesion lengths. If patient have clear proximal cap, if he have no collaterals, if length is less than 20 millimeters, preferable is antegrade approach. If patient don't have clear proximal cap, if length is more than 20 millimeters and patient have good collaterals, we can go retrograde. What we see in largest registries, EuroCTO Club CTO registry is the largest registry, ongoing registry in the world. More than 50 centers participate in this registry, more than 100 operators. And what we see? We see that retrograde approach have become more and more popular. Last year, more than 30% of cases was done using retrograde approach. Dissection reentry technique also becomes more and more popular, but till now it is still only 3% of cases. Due to more wide usage of retrograde approach, also we can see that procedures become longer and more complex. But this is one of the main reasons, more wide usage of retrograde approach. How can we reach better result? In EuroCTO Club is near 19%. We can see that more dissection reentry technique, but technical success rate is very similar to EuroCTO Club. It's near 90%. Ways are different how can we reach result, but no final result, as we see, are very similar. Thank you for attention.
A very nice overview of the entire CTO space, including the more recent contemporary data. And I think it's very clear that in order to be a successful CTO PCI operator, that not only the antegrade skills are important, but you must be able to perform retrograde. CTO, Dr. Saito. Good afternoon, Dr. Saito.
Good afternoon. Yeah. You can hear me?
Yes, we can see you, Dr. Saito.
Can you hear us?
Can I have IVAS? Okay. This patient is an interesting patient. He came to this hospital several infarction, and coronary angiography was performed, and it showed the total occlusion of the right coronary artery as well as the total occlusion of LAD. And initially the patient was scheduled to have a bypass surgery, but because of this meeting, that procedure was postponed. And today I started from the right coronary angiography from the catheter, and the lesion was crossed easily by using a regular workhorse wire like this. And then I tried to put the IVAS catheter, but of course it could not pass through. So this is a 2.5 millimeter balloon predilatation. I did it. However, still, okay, and after this, we did IVUS, and
Show
okay,
the IVUS picture.
I can show you the IVUS.
Show.
Yes, we see the
great.
IVUS.
Start. Okay, this is a far distal, and the distal part is quite normal. And now, maybe very soon, you can find some plaque. Yes, plaque is coming, but not so bad
Yeah.
at this part. You know, this part is maybe 2 or 3 centimeter distal to the occlusion site. So this is very far. Okay, you can see another plaque accumulation, but still the lumen is patent. And then coming to the proximal part, we can see a lot of plaque.
So good sized vessel, almost 3.5.
Okay. Yes,
Yeah.
that's right. So this is the most significant part, I guess. And the classification is not so severe. It's a soft plaque. Okay, here, a lot of plaque. And here is positive remodeling.
And an attenuated plaque, you can just see plaque.
So significantly long lesion
Okay,
as well.
then can I see? Yeah, can I see the angiography?
Next one.
Okay, this is okay. This is a region, very long, and most this part is a kind of spasm. Okay, next, and after injecting nitroglycerin, this is no next.
It's almost 80 millimeters.
This
of
is
disease.
after injecting nitroglycerin. Yeah. Yes. So the question is which size of the stent? The diameter of the stent should be 3.5 at least, maybe.
Yes.
But the problem is the length. So the here is the 60 millimeter
Go back, go
tapered stent, tapering from 3.5 to 3. So I took that one. Go back.
Go back.
Yes. Yeah.
No. Stent, just keep it.
Yes, this was a 60 millimeter stent. The stent deployment was so difficult. So I was taking some kind of a technique, to increase backup support, and then stent gradually passed through.
Very nice. So
This is the biomine. Okay, next.
Next view. Andrew, next view.
Okay, the position is fine. So this was stent implantation by using 14 atmosphere. Okay, and next we do.
3.5 post-pulmonary.
Looks beautiful.
This is 3.5 millimeter. Yeah. And now I am taking a 3.5 millimeter high pressure balloon to post dilate this long stent. I think this is a very long stent, so the post dilatation is much more important.
yes, the proximal is almost a 4.0. So
Yeah, again, it's difficult. Okay, can close. Okay, starting from around here, maybe.
Negative.
This is 10,
Yep. Going up to 10.
10, going up to 10.
Yeah.
Okay. And now coming proximal 12.
12. Yeah.
Okay. Deflate. And
so
14.
this is the culprit vessel in the ACS. Is that correct?
14.
Yes, culprit.
Yeah, that's why there was a little bit of a
16.
slope.
Yes,
So you
that's
could
right.
see a lot of attenuated plaque.
Yeah.
Okay. Okay, 16.
16.
Okay, come down. So, okay,
Ibis releases.
can I take Ibis?
Yeah.
Anyway, at this moment,
No?
Anyway, at this moment, there is no EKG change.
Hello, hello. हाँ अच्छा 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 ठीक है ठीक है ठीक है
यहाँ का नंबर चाहिए हमको।
ओके ओके वो उसका वहाँ का नंबर दे रहा है तेरे को ठीक है
ऐसे करते मेरे को दिया तेरे को अभी ऑडियो ठीक आ रहा है अभी तेरे पट के आ रहा माइक के पास ही था मैं अभी माइक ऑन था ना ये हाँ भाई तू तेरा माइक ठीक नहीं आ रहा हाँ मेरा ठीक आ रहा है तू कह रहा है हेलो 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 मेरा क्लियर है उसका क्लियर नहीं है भाई देखो ये क्लियर है वो क्लियर नहीं है चेक करा रहा हूँ हेलो 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 माइक चेक 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 1 2 3 4 5 6 7 8 9 2 3 4 5 6 7 8 1 2 3 4 5 6 7 8 9 10 अब ठीक है हेलो हेलो माइक चेक 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 हेलो 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 माइक चेक 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 लेवल कम है लेवल हां बोल
हेलो चेक 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 हेलो 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 चेक चेक हेलो चेक 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 1 2 3 4 5 6 7 8 9 10 हेलो चेक 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 चेक
अच्छा तेरे को यहाँ पे क्या चाहिए मैम पूछते हैं लैपटॉप की
हाँ लैपटॉप चाहिए ना पीपीटी चलाने के लिए
अच्छा पीपीटी आपके पास
नहीं हमारे पास हेलो 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 चेक 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 हेलो चेक 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 हेलो 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 चेक 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 हेलो 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 हेलो
इसको पैच करा देंगे लाइन को बाकी मेन लाइन बैकअप लाइन तेरे को एसएमएस कर दो साइड हो जा साइड नंबर लास्ट में क्या था
Hello. Hello. So one from Bombay, Godrej Hospital, actually two from Bombay, and one we might have a PPT by Dr. Saito from Chennai. वो बचा हुआ
चेक चेक हेलो हेलो
हेलो
हेलो हेलो उज्जवल सर
हाँ जी
हाँ सर
ऑडियो मिल रहा है ना आपको
हेलो हाँ मिल रहा है सर हाँ मिल रहा है
आप बोलो एक बार
हेलो
बोलो बोलो
हेलो चेक 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 हेलो 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 चेक 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 हमारा पलक कलच बना
तो लेवल इंक्रीज करो
हेलो
थोड़ा लेवल बढ़ाओ
उज्जवल सर
पेन की लेवल कम आ रहा है
एक हेलो 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 चेक 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 हेलो 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 चेक 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 हेलो 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 ठीक है सर चेक 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 हेलो हेलो चेक 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 हेलो 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 वन हैं
थोड़ा लेवल इंक्रीज करो लेवल कितना टीवी रखा हुआ अभी
लेबल सर है मैंने हैं कर दिया है
इसको नीचे रख थोड़ा 75% होना चाहिए
हेलो 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 चेक 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 ठीक है सर हाँ हाँ पहना हुआ है सर हाँ हाँ
ठीक है भैया और
ठीक है सर
आपको सिर्फ कैमरा और एक पीपी कोई है ना माइक ही है बस और एक पीपी लैपटॉप ऑफिस सेट में लगाएंगे
लैपटॉप अभी आया नहीं है सर
ठीक है
वो आ रहे हैं सतीश भाई तो लेकर आएंगे
ठीक है ओके उसको बंद करो मैं चेन्नई वापस
ठीक है
जा रहा हूँ सुबोध भैया को बोल दो बंद कर देंगे
ठीक है मैं कर देता हूँ चेन्नई पैच तेरा मैं कर देता हूँ मैं पैच कर देता हूँ चेन्नई तेरा
ठीक है कर दो इसको बंद करके चेन्नई
उज्जवल हाँ कर रहा हूँ ठीक है ओके
Then we'll bring you back and check again. If we can do it, at that time we'll do it. You'll be able to catch the flight?
2 minutes. Then we'll
Okay, right. So we'll have one live case, a few talks, then come back to live case. Yes. Yeah, please come up. Yeah, please come.
Dr. Munawar, stop.
Start my left main.
That's right.
Right.
That's right.
Why not?
Doctor, let's have Dr. Lee come on up. It's a bifurcation case, I believe, and then after that we'll have Dr. Munawar give his talk on bifurcations. So let's go live.
Let's go. What a rain? Okay.
3 to 4 minutes. Get him credit. Munawar cut. Okay.
Yes, we are ready.
Yeah, we're ready. Hi, Samin.
Hello.
Hello. We can see you.
Yes.
Okay, good. So the Manish and Dr. Kaul and
Yes, Samin.
rest of the our panelists, we welcome, yes, simple kind of a warm-up, and the second one will be the left main.
Great.
So I ask Dr. Chetan to present the history of the case.
This is a young lady, 49-year-old lady, who presented with history of rest angina, and ECG showed a non-cave anterior wall myocardial infarction. And an angio was done about 3 days ago. And can we have the angio shoots to show them?
Okay, we see the angio.
Yeah. No, that's okay. You keep it here. No, it's playing. Yeah. No, this one, us. Yeah, good. Okay. So as we said that this afternoon session is a bifurcation. So this is kind of a 0, 1, 0, because the lesion is only in the distal segment of the bifurcation, and seems to be the both diagonals and proximal segment of the LED are preserved. But very angulated vessel, big mismatch in the proximal vessel to the distal.
Yeah, we see that nicely.
Yeah, and diffuse.
Yep. So we have selected initial dilatation. That do we need to protect TCA and then subsequent long stent to cover both the lesions?
Yeah, so this is a very good discussion for provisional bifurcation, Dr. Sharma. It's a nice case.
Yeah.
So what is a 6 French radial system?
It's a 6 French radial, and actually patient had a radial procedure a few days ago.
Okay.
They were still able to go through it. Slightly painful, but you know which happens.
A long segment of disease.
Good. Now the wire has gone. We are given a heparin, 7,000 heparin. You ready with the balloon? 515 mosaic.
Okay, when do you protect the side branch in this case? Even though you're not going to stent it, your approach is provisional. When do you decide you're going to wire it or not wire it?
I can tell you I have very low threshold of protecting the side branch with a wire. And remember, there is a latest paper last year, one registry had almost 18-20% side branch occlusion, even in the cases where there was no disease. And that there was no side branch wire was used for protection. So I actually have a very low threshold. So my recommendation here will be that after we do initial dilatation, so that we just put a wire into the side branch and then stent across.
So your approach is after pre-dilating to put a wire in, not pre. Okay.
You know, wire movement and all, some get crisscross, and so.
That's a great,
Okay,
yeah.
And particularly there is no disease here. Yeah, that's kind of. But if there is a mild disease or mild to moderate, then I would start with the wire to begin with.
Front, yeah.
Go.
You can tell them the balloon.
Yeah. No, okay, slow. Many times it's angulated, you have to go slow, otherwise it will push back. 1 second.
Go very slow on dilatation.
Go 2. It's a 2.5, 15, 2.5, 15 mosaic NC balloon. 4. 6. Maybe 2.5 is little too big for the vessel.
Again, slip back.
Negative. Yeah. But we go a little further. It's pushing it out again.
5, 6, 7, 8, 9, 10.
Very, very fibrotic lesion.
Yeah, here it
Yes,
opens.
very fibroid. And although it looks acute syndrome, patient has a troponin positive.
Yeah.
Okay.
Yes,
Let's go
positive.
distal.
You want to size?
A little further. No, just dilate here. Yeah, dilate here. Good. Okay.
Down.
Yep. We'll take a picture now. Come back in the guide. No, bring the balloon in the guide. Yeah, good. Cine. Go to a little more RO. Slightly. Good. 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 Yeah, I think there is a little distal dissection which
Yeah,
is okay.
distal dissection.
As long as your wire is good. So, yeah. Yeah. Sided the 44 millimeter diagonal. Give us this. Give us this and play the last view so we can see it a little better. No, give the wire. Yeah, good. So good. So we have the second cyan blue because cyan blue is the workhorse here. Good.
That's a very good wire, the cyan blue.
Actually, I know that a lot of people really love it. We did try quite a bit at Sinai, but part of that is still wire for us there. But this, a lot of people love cyan blue. Manish, what is your work?
Samurai wire.
Which one is that?
Which is a Boston Scientific wire, which is a fantastic steel workhorse wire. It's an advantage over the Pro Water.
Leave it there.
But all these are very good wires. It depends on what you're using.
That's right. I think they're nearly equivalent.
2.5,
Yeah.
right?
What you're used to should be the choice.
2.75 or 2.5?
2.5. We are 2.5. 2.5. Here, let's play the last one. We decide with the vessel size and the length. I think we go with the 2.5.
Yeah.
So you have a long lesion, huh? Samin?
Yeah, he's
Yep.
short.
So 2.5, 44. Yep. 2.5, 44 millimeter. Yeah. Show other way. This is called biomime or 65? 65 micron. Just like.
And you sure
Dr. Cole, what is your
that
wire?
the distal
Workhorse wire.
section is protected with this
Hello?
length, yes?
Yeah, I usually use BMW, Universal. That's our workhorse.
I'm sorry?
They should ensure that the distal
Great wire.
section will be covered by the stent
Yes,
because
yes,
the,
yes,
the
yes,
distal
yes.
section is
It's using a 44
evaluating,
millimeter.
yes?
Yeah.
Yes.
Yes.
But I agree, the BMW is a good wire. In Brazil, we use a lot.
Yeah.
Even though in our acute case
That's
of
a little
EMI,
too long, but
we
that's
have a
okay.
good experience.
Yeah, I think the 40 would have been fine, but we had the 44 here, and we'll take a little picture. Good?
Yeah.
It covers nicely. Good. Go up.
Yeah.
Yes. Seems good.
9, 10, 11, 12.
Good. Okay, let's say yeah. अब थोड़ा दर्द होगा अभी.
और दुकेश?
Negative. Yeah, I think we can just post dilate with the 2.5 balloon we have. Go once again. We usually go 2 times. The idea is the second time you have a little better expansion of the stent against the resistance of the lesion.
Yeah, I agree. Yeah, I
10,
always
12.
go twice as well.
12. Good.
Okay.
Especially with these delivery
Negative.
balloons that are very semi-compliant and compliant.
Right. Recross it and then post dilate. So I think we'll ask everybody's opinion. Let's bring this one the guide. Good.
How many atmospheres do you use in deployment of stents in this time?
This one was 12 atmosphere.
12 atmospheres.
Yeah, my approach to that question is if I take a picture and there's good flow,
Yeah.
then I will
Take it out.
pull the wire out
Yes.
and rewire it and finish with my non-compliant balloons and not necessarily do kissing, but just have it ready if I need to. But here the pot will be
Right.
important
That's right.
because there's a
Good.
very large proximal segment compared to the distal
And
segment.
the site of the lesion needs,
We'll take
more
out the
work.
wire and
Fluoro.
rewire.
Yeah.
Yes. I
Go on
completely
forward now.
agree with Professor Manish. This is our approach in Brazil. Professor Eduardo Souza taught me this even in my earliest days.
What is?
Give us some suggestion.
And let's, yeah. So likely what we'll do the same, we'll just change the wires.
Swap wires.
And take the main vessel wire and cross the side branch. Why she's getting so? You will die. No, diagonal was good.
Almost there. No.
It's okay.
Right up.
Now somehow patient, whether it's an acute stretch, because we have very good flow. Show the last picture. There is no edge dissection, everything looks very good, but patient had a lot of chest pain. Go. Yeah, the proximal, I think we may need a 3/0 balloon.
Yes.
Yeah, you'll need to proximally
Or even
optimize.
3.25. Good. Advance the side branch wire. 1 second, 1 second. No. 1 second. 1 second. See that wire happen? That once you have a soft portion of the wire, distort that wire. Good.
Okay.
Good. Okay, go on. 14, 16, 18. Good. Negative. Okay, go up here. 12, 14, negative. Okay, go up here, negative. Okay, so now we take the picture and then we decide what else need to be done. Sorry. Good. Everything looking very good. We just had to pre-dilate now. The Manish, in lieu of the time, if you want to go to your lecture, will give us about 45 minutes here to get the left main case ready.
Very good.
Okay.
Or
Very
any
good.
questions
Very
you have
nice,
to us.
Very nice demonstration of a provisional case.
Excellent.
Okay. Thank you. Thank you.
Okay, so let's introduce, having seen a bifurcation, really an expert in all complex PCI, Dr. Mohammed Munawar will be presenting on bifurcation tips and tricks. Dr. Munawar, thank you.
Thank you.
Good afternoon, everybody. And the first of all of us, of course, thanks very much for Miller Company for inviting me to be here. This is the first time in Vapi, Gujarat, India, but the third time in India. So my task is actually about bifurcation. And I think it's during the last 25 years we are witnesses as progression of the bifurcation. In the past, just if you look at the bifurcation, put the balloon or stand in without considering of the side branch. But today we are talking about bifurcation technique stenting, not one by one, because too many technique that I suggest you just do with 2 or 3 kind of the technique. But what I'm sharing with you is that at least 2 or 3 concepts of the bifurcation. The first is what we call in bifurcation. In the past, just you see that in the proximal part of the bifurcation is similar with the distal part of bifurcation. This is true when the side branch is very, very small. But if the side branch is significant diameter, then we have to consider regarding the Murray law. It's finally with simple mathematical model that the main branch is 0.67 multiplied by the sum of the diameter of the side branch and the distal part of the main branch. So, for examples, if you see like this, the left main is quite large, might be 4.5 millimeters, and the LED 3.5 UX is about 3.2. So don't, I mean, that's in doubt that at least you can put the stand 3.0. This is not without a limitation. If the laser is diffused from the proximal to the end, then might be the Finney laws cannot be applied very accurately. Or on the other hand, you have to do with the nowadays it's become very in the dealing with the bifurcation is POT, proximal optimizing technique, that we have to do in every bifurcation because if you do like this, I mean, that's if your sizing is proximal part of the main branch, then of course the result is kind of safe. That's true. So what we have to do is actually you have to do with the vanilla, then of the main branch, then of course finally not only just to make more coverage of the side branch, but so the result should be very, very good. This is two basic concept when you are dealing with bifurcation. Of course, the objective, the target of the doing bifurcation is optimal rheology, and stands should be well opposed. And of course, if you have IFS imaging, that must be very, very good. And the thing is that in the end of the day, if you have something problem with the reuse or something like that, so it's very easy to access for. And in the real world, I think is everybody knows here that at least there are two strategies for dealing with the bifurcation. One is that single stand strategy, and the second is double stand strategy. We do like you can see the just live demonstration, small side branch, or like the case that's already shown in line. A proximal side branch is no disease at all. Sometimes just put the stand in, then port, and then that's okay. And the second point is that we can use culotte technique, classical cross, mini cross, and recently DK cross, and freestanding or simultaneous kissing stand, and T-stick. Which the technique that we can use, I think, is depend on familiarity of the operator of using that. But I mean that the main point is that how to make the stand cover of the part of the bifurcation. There are some in our lab in the last 2-3 years, we are familiar with the decay crest and T-stenting. I mean that's a recent technique. We use decay crest and T-stenting. There are some advantages and disadvantages for those. like using a radial I think it is a balloon POT here, and then this is a final result. Yeah. So this is one step strategy. So if culotte technique is actually a bit complicated, but I mean that's in the past when DES is not available, this is most of the intervention is not like this technique because of so many instant restenosis. But nowadays is with the DES, I think is instant restenosis is not become big issue. And what we have to do is that put stand inside brands and then and balloon. This is a technique of the culotte with from the radial approach. You can see here that very tight stenosis from the left main to the LED, and I think it's made in a 111. So we the circumflex stand at left main to circumflex. Then POT. Then we put at LED, open up. Then re-POT, and finally kissing. Finally, so cross technique, mini cross technique is quite similar, but you have to put two stand in. That's why we have to have with 7 or 8 friends getting catheter. So the first thing we have to open the side branch first, and then cross with the stand in the main branch. Then we are recrossing. The problem is recross because there's so many layers, and then finally we are doing POT, and then final kissing inflation is stand technique, and then finally we have to kissing balloon. This is one of the example of the using DK cross. 2 wire in, then you have to open up with both sides and put stand in the side branch. Then recrossing, yeah. Then open up with the balloon, yes. Then recrossing and ballooning, and finally a final result. So TAP is one of the techniques stenting, and the limitation of the T stenting is that the risk of incomplete. You can see in the stand picture in the upper, that's cannot of the side branch within the main vessel. Sometimes quite big. This is the limitation of the stenting, but we can.
Thing. Second criteria, although we like OCT imaging tool for left main technology, and I think squared or less. Now I know that our partners in Korea seem to have a slightly smaller amount to treat, suggesting that this is an appropriate osteal or shaft left. Sometimes if the distal left main is involved, and more than AD, and more than 3/4 of them into the circumflex main. Clearly, it depends on where you're practicing, respective angiographic tool, which is, but it's allows the patient to utilize very rarely in the United States outside of. Always, we will calculate an STS score, a syntax score, have a conversation with the family and with the surgeon before we proceed. As you see here in the United States, looking at the 2014 ACC AHA stable ischemic heart disease guidelines with mortality over 2%, and with CABG having a 1B for all 3 of those, and then the lowest syntax score having a 1B, 2A level evidence B for intermediate syntax scores, and a class 3 level of evidence B for the high syntax score. Now, very interestingly, if you look at heart failure with low ejection fractions and in the diabetic population, this coronary bypass territories and appropriate coronary bypass patients. In the United States, left main, unprotected left main PCI has gone up with the default strategy when patients have high STS and surgical risks. Now, left main coronary revascularization in the ACS population does have an ACCHA guideline, especially for patients who are in shock, and urgent coronary bypass grafting is not something that's an option. What are the techniques and what are the results? Well, what we know clearly is that our current contemporary limus drug-eluting stents are safe and effective. Here is zodorolimus versus everolimus in the ISAR left main 2 trial. This is looking at 12-month data published in JACC of the everolimus drug-eluting stents over zodorolimus. If you looked at the pooled ISAR left main 3-year major adverse cardiovascular events, again, clearly you see in the low syntax score a much lower 3 score rates. And if you're going to do left main, it is in my practice to not do it if you have intravascular and you're not good enough to do angiography alone if you're going to do left main PCI in a stent recently polygon, the R squared, and clearly this is in the Asian population. In the United States, we're doing and looking for by eye very, very important numbers because it does predict restenosis. If you're going to do left main PCI, it behooves you when you're using imaging to stent to IVUS from the LAD back and from the CIRC back in 2 separate. What we do see with patterns of most left circumflex. When we see restenosis, it's and clearly that's under expansion, 1 versus 2 stent techniques. In the 2 stent technique, the left stent, circumflex stent, was most frequently underexpanded and results in ISR more than half of the cases. Under expansion in the 1 stent technique is less common. Very little one strategy. When you have bifurcation, what we call a true bifurcation, this circumflexes are not small vessels, and oftentimes you're going to end up having strategy. As Dr. Munawar pointed out, if you're often some disease in the arms, contrast when you have stents, or if you're going to have a vein graft, or you need to do clearly the balloon pump, especially when patients have no reflow, and using the Impella device, and sometimes in the direst situations. So oftentimes these are the type of, many of these, can you get away with 6 French? You're not going to do it. The other thing you're going to need to remember is if you're using DES, and I'm not going to talk about BRS left main stenting at all today, but if you're going to use is acceptable, especially for and doing a 2 stent technique or doing a mains. That will be smaller than 4 millimeters. 5. We do now have expansion ranges. No longer is that enough. The proximal optimization are clearly better than when you do not. In a patient with heart failure and intrusion of the LAD, most important to make sure that you cover both accurately. You will have a little bit hanging out. You don't want to miss the balloon back because oftentimes if you have the guide right at and you potentially can cause longitudinal compression, and you've now unsurfaced or unstented an area that needed to be stented. And the balloons are bulky, tend to prevent that, but I can tell you, you will see this in any of the standard drug-eluting stent technologies that we have available. So here's a couple of cases. This is a patient with 78-year-old with Hodgkin's, lymphoma, radiation and chemo, prior coronary disease. Big enough, we did not remanipulate that. We finished with a POT of 4.5 millimeter balloon at high pressures, and this was the final treatment. Now here, the circumflex was 6 millimeters squared on IVUS as well, and we decided to not leave well for a period of time. Came back with recurrent angina. Can you hit that, please? Almost a year and a half later, run it, please. And what do we have? Restenosis at the ostium of the... And so what do? Here we ended up double wiring it, essentially converting this into a TN protrusion with a blocking balloon. We have a blocking balloon, the LAD. There was finished optimization to take care of this. And the patient has done well. But again, if you do see restenosis, oftentimes the circumflex is where we will see it. This is a 75-year-old patient of mine, smoked. Here, it's challenging unless you put an axillary balloon pump or impella, which I didn't want to do. Hit it again, please. With a retroflex circ, hit it again, please. Hit it again, please. STS mortality score. His STS is bad not disease. Next slide, please. Here's an AP cranial. So we put a swan in him, we hydrated him, we got his wedge up to 16. His creatinine is 2, so we limited the amount of dye. So this is a case that you need to plan soup to nuts. So it's going to be, I wired the LAD and dye. Here, this is an 8-friend. They provisionally finished with post-dilating the LAD. Next picture, please. This is a 303 Zions. Next. Okay, left the diagonal as is. Did a POT. Next, 4023, keep hitting it. In the circumflex. Contrast. Next, dynamic. Next. And we were happy with this result. And this procedure, soup to nuts, can be done with very little radiation, very little contact. We need to watch. There are going to be 2 very exciting presentations at TCT this year. First is going to be Excel, which is the Zions Prime versus Cabbage, 2,600 patients, primary outcome, at least from what we're hearing. So how do we improve left main PCI outcomes? Clearly, you need to thienopyridine preload, statin preload. We like to use, if we're going to have a patient with a high risk of bleeding, bivalirudin. We like to use IVUS and FFR. We like to guide our stenting with imaging. And I follow these patients clinically. In summary, the left main coronary disease is the only is unequivocally accepted as improving survival implications when considering diagnostic tests in the context of the ischemia trial. As outlined in the updated ESC guideline, PCI is becoming more accepted as a primary treatment modality of left main disease, especially in patients at higher surgical risk.
Thank you very much, Manish, for this elegant and lecture with all the tips and tricks which you showed. I'm sure that it's going to benefit all of us in the near future as well as today. Do we go to the live case now, or I think Dr.
I would like to say thank you to Mario for this, and Mario, especially Sanjay, because in our services I had the opportunity to use about more than one in one of our surgical to is really really need to have activities and reserve survivance for our surviving in this competition that is in cardiology today. So this is a virtual cycle. Teaching and research is continuously feeding the virtual cycle of medicine in cardiology is not different. And Mario's team in São Paulo, Brazil, have students at college and all sometimes post-graduation students and fellows. And at the other picture, we have graduation team that they are making their initial, and our professor, titular Professor Chagas, was to show Japanese governor in this American, and we give share is made in these efforts, and we are really proud about an example. One of these studies is a registry, a non-randomized trial for this biomime use in the capital cities and the other cities in our country. This is an example of CRF model. This biomime It's a non-randomized trial. It's a multi-center national study. So, on the edge of challenge of our specialty, we have this research and teaching really important to us. But it's really remarkable that we must do and perform with excellence our selected some cases, groups of patients that are really highlighted in sessions like this. Chose it multi-arterial of a tight lesion in a male patient who was 46 years old, calcified, unstable angina. This is an example. Let me. Pills is an and despite of this is for and perform this case made the choice of a long stent, but the is a biomime 3.040 millimeters, and then we perform the post dilatation. Oh, please, this is an angel, please. This is the final result. Sorry about the guide wire. In another case, we have a case with tortuosity and angulated curvature. A male patient with 65 years old. This is really interesting case because we have a curve of 100 culprit lesion. In this case is this circle because the right coronary artery is a chronic total occlusion. The outstanding image of 9. And then, please, the next angel, and in a good result. Patient with 6 years old, with previous cavity and calcification lesion. In the case of no, it was really challenging because you're gonna see in the next angel the curvature in S that the stent goes. 2.5 by 35 millimeters. Even though using an extra backup catheter, we saw the catheter pull back, but it's really interesting this image. And this is the final result of this stent, in this case of a patient with a previous CABG. This is one case of a female patient, 47 years old, instead of the LST elevation in her AKG. Please show the angel. This is the final result, showing that these devices are used in even more complex territories today. And this is a really interesting case of a male patient, 57 years old, with a CTO of LAD, diabetes mellitus, functional test positive, and as this woman has this stable angina, the referring physician asked us to open this LAD, and this is a real this device. You can see the total occlusion there. It's really challenging. In the next angiogram, you can see the final result with a 2.25 40 millimeters biomime stent. Yes, could you perform the angio again, please? The revascularization. So, this is my experience to biomime. I would like to say again thank you to Mario, and this is for show us that we are just human. The creative innovation spirit has always been present in us like human race. Even though in the 20th century, more than 1,000 years ago, Genghis Khan in his empire, that was wide more than 1,000 kilometers, has a system of communication that allows Wi-Fi, but forget that the most important is the creative spirit that has been in human race all this time. Thank you so much.
Thank you very much, Dr. Luciano, for sharing your experience with biomime stents and showing such excellent. Are we ready for the case now?
Dr. Sharma for
Put us live.
PCI.
Yep. Okay.
Yes, Samin, did you get some lunch?
Careful. Yes, we got a good one.
Good.
3:13 is good.
Okay.
Okay, welcome back. Again from Godrej Memorial Hospital, and I had Dr.
Good afternoon, everyone. This is a 66-year-old male gentleman who presented to us with an anterior wall non-ST elevation MI troponin positive. Ejection fraction is about 35. So the angio disease. Can we show the angio? Or show this? Yeah.
Good.
Yeah.
We are not given much dye because patient is coughing. To me, that usually means high EDP. We are given the IV Lasix. We are giving a beta blocker 2.5, and the patient settling down a little bit. And lecture about the left, and that these kind of lesions in the past go back to ostial left main. So our goal is now to protect, also cover the circumflex, because and after kissing balloon dilatation, will cover the ostium of the circ, and maybe that will be good enough. What is your feeling?
So the approach, Samin, I'm hearing is stenting from that proximity back to the ostium of the left main in a single stent strategy, and then assessing
the stent in the circ. You don't need the picture. Yeah. Keep it as a bailout.
I would keep it as a bailout. Yeah.
Circ definitely has. Yeah.
10.
Bailout. Yeah.
10. 12.
10, 12.
Okay.
Good.
Negative.
Okay. So what we do?
8, 10, 12.
12. 14.
14. Yeah.
Good. This is 30, 13, 13 mosaic, NC.
Yeah. Eleva caudal, please.
Yeah, this is but we'll take a picture now. Ian.
Yeah, I would favor, you can always treat it if you needed to afterwards, if you feel like you need to predilate, but I think if you can get away with a one stent technique, that would be best.
Good. Okay, so good. So go back to our previous view, and we go with the 3.1.
Cover the ostium of the left and
Up
everything.
to
Okay.
Yeah.
Or 2 stents, one in the ostium 4O and then 3.5 to LED.
Yeah,
like
we can use. Would be
Well, I mean, I think you have.
no.
Biomime
No,
of 435.
but you need a 4.0 for the
You
proximal.
have 4035? No. Biomime of 4035? No.
No, they don't make
It's
it,
only
right?
3.5.
Good.
Yeah.
Yeah. So we can take a 3.5 what, a 32 or 37, which we can cover completely.
37.
I think 3. Yeah. I think 3 will cover a 2.5 balloon. Yeah. Out the IVAS and but other that but we don't have the IVAS here yet.
No, we don't have this.
So we'll just go with our clinical sense.
Hai na? 4.5, no? Very good.
Good. Take the stent.
Stay.
Good. The point is, one should want to do overlap, avoid the overlap at the side branch. So idea would be that if we are using 2 stent, we'll end one stent in the mid. Good. Get ready. Yeah. Go to the view which we had earlier.
This one. Okay.
Pull back the LED wire. Good. Good. That's fine. Yeah. Okay. Now take the guide out slightly. Good. Let's go, Sine. No, you're too far.
Yeah,
No.
my stand is too inside.
No, yeah. You don't need yet. Good. Okay. Let's take a picture here.
No. Cranial.
Proximally, we have to pull back a little bit. Let's see. Pull back a little bit proximally.
Okay.
Sorry. Yeah. No.
I think we have to
This may be too much here.
Yeah, you can go in.
Okay. Bring the guide in. Yep.
Yeah, guide is in.
Okay. Now, Cine?
It's still out too much.
Or question it? Yeah.
Yeah.
Okay, no, but guide has to come in.
Yeah.
You won't know anything otherwise.
Yeah.
I think maybe okay.
I think this looks okay. Sir.
Okay.
Could we
Go to RO caudal again. The or AP caudal.
AP caudal?
Little more caudal.
Deep caudal, please.
Good. No. You have to. Good. Cine now. So we know exactly. I think we need to go inside more.
An LAO-cranial might be more helpful here.
Good. Okay. No, a little too much here. Pull back. Go to aleocranial. That's another good view to coverage of the ostium. Okay. Good. This actually is better coverage. Pull back a little more.
Yeah. Okay.
I think we are okay, right?
I think you're right there.
Everybody agrees?
Yep.
I think that looks good, precise.
Yeah. Last one.
Good. Now you have to pull back 2 millimeter more.
ये freeze दे दो मेरे को. Can I have this freeze frame, please? Thank you. Put it there. Bus. Thanks.
Just 2 millimeter.
Yeah.
One more strut back. Okay? Yep. Ostium? 12. And then we can saturate. Just go up quickly again. Again 14 atmosphere.
6, 8, 10, 12, 14. 13, 14.
Yeah.
Negative.
These kind of cases in the past, we used to put a balloon pump, impala case. If you think that patient hemodynamically unstable, high EDP, then you need some support. But patient responded to our medical therapy, became stabilized, saturation was 98%, and then we went ahead with although we had a balloon pump ready in the room.
Yeah, I think we've covered those.
Yeah, good, very good. Let's go to other view. Same our caudal view, and we.
0.5 for the ostium of the LA.
I think we can just. Good. Okay. So first thing, same thing we'll do. We'll take the wire out of the circumflex and then recross it. Actually, we saw that even earlier case, that not even a 5% pinch. So this is with the biomam design. Yeah, same, the two ways. Either you bring out the wire, make a sheet to. Also, a little still end of the, never be able to expand it.
That's a very good point in the provisional stenting is to recross at the most distant.
Bring the guy, take the needle out. Now take a cine. There is a little pinch of the circumflex. And it always went out. But the septal remains nicely. Diagonals all good, no pinch. Show it. Okay, 10. Go up. Yep, go on here. Yeah. 10, 12.
Get it back a little. Can you go to the cranial view, please? AP cranial.
Good. Balloon more out. Good.
Just see. Yeah.
Yeah. Go up.
Okay. Go.
Good.
Dr. Calvin to the mirrors.
8, 10, 12, 14.
4.5, but then there is a second top of the balloon, 8 or 12 millimeter balloon, ostial flash balloon. In the renal and of course the ostial vessels, particularly the right coronary.
Yeah, absolutely. I don't tend to use it in the left main.
Beautiful. Good. Go to the caudal view. You can take the wires out and take the pictures.
Yeah.
Looks very good. Take the wires out. Good.
That looks great,
Perfect.
Samin. Looks great.
No EKG changes. Patient doing very good. Always comes in these cases. Should you do a routine kissing balloon dilatation? As we know, in the non-left main, that question had been answered by various trials, like Nordic bifurcation 3 and others. But for the left main, that question will be answered, where for the single stent technique, just leave a balloon. So clearly that one stent technique, whether you do a routine kissing or not, we'll have probably 200-300 cases of the people who did a routine kissing, which is okay to leave it, that don't go a single stent technique.
No, I think that's a very good point, and it's simply beautiful demonstration. Okay, so let's, we're all due for a, take 10 minutes and. That case.
Who is the pro? Very aggressively, talks very What can be done was
Support or not? Both sides are coming. So many. Yes. Dr. Kaul?
Thank you, Manish. It's a privilege to be talking about bioresorbable PLA-based sirolimus. Is the second generation is a stent which is BRS. Number one, to cover multitude of morphologies, sizes and dimensions are multiple, as we'll be seeing. And because of that, we can cross the clinical spectrum, not only generations of the design from the earlier generation. And this has been possible by improved manufacturing process in order to retain the radial strength. One of the very important things is that the strut thickness has been reduced from 150 microns to 100 microns. Markers, shell radio-opaque markers will be all the biomime stents. It has a hybrid cell design. That means closed in 2 years based upon PDLLA and serum absorb on the right side and Maris on the ness, allowing for a low profile delivery system. The average profile of this stent is 1.2 in comparison to 1.4 of the Abbott BR. With the Maris as compared to days is lower. Blue is the Maris and yellow green is the absorb. And as you can also see, the percentage of stenosis after deploying in animal models in 90 days. Once again, that the nominal scaffolding of absorb mark. If you can just click the, you can see the markers. You can sort of see the stent edges as 3 dimensions, and they're very well visible, which is late. And this is what is unique: large metric size, 2.25 to 4.5 diameters, and average available lengths are going to be from 8 millimeters to 40 millimeters. So that's going to mean that a large, number of patients is like in any other within a period of about 30 days, 40 days, and the polymer gets eluted by 3 months. Of the scaffold is in the crystallinity, and by the first 2 year program is originally, and then between Maris 100. So about 4,000 patients are planned to be studied in a phased fashion, and we should be having the results within a couple of years. Now coming to the F1, and as I already told, the clinical endpoint in this is major adverse cardiac events at 6 months, and this is necessary for the approval from the Drug Controller General of India, and 6 months follow-up is about to be finished within 6 weeks. And this is the investigating team. We have core lab being to assess the safety and performance of this stent in de novo coronary lesions as indicated by proportion of population reporting with ischemia-driven major adverse cardiac events. and secondary objectives like evaluation of population resulting reporting with MACE, but OCT. Now, this is the acute coronary syndrome. This is a relatively, complex lesion from the ostium onwards. We deployed. Pre-dilatation done. Can we run it again? Yeah. So the stent is being deployed. Run it. The second one. Yes. And then the post, we know that we're not within the stent. Click on the last one. Click on the last frame. Yeah, click on this. Yes. What happened anyway? Anyway, that showed the final picture. Click on it. Post deployment showing the thinner struts. Those who are used to the absorb, you can make out the difference between the struts thicknesses, and you can see it's very well opposed after the post-stent dilatation. This is a case which was done in Meris Extend by Dr. Abizad, I think a few days ago, and this you can see is a anomalously arising right coronary artery is arising close to the left coronary sinus, and yeah, and you can see this is how you can see how the stent tracks. That's because of its lower profile. You can see that it is very well tracked even in the situation where the guide catheter support is not so good. And that is the lesion, and this is the Meris being deployed next. That is the final result. This is the post-deployment dilatation with a bigger balloon by 0.5 millimeters. A very good final outcome. And this is something which is going to come. This is the Meris stent, which is going to be available with the embolic protection for use in thrombus-containing lesions. Sirolimus deployment is going to be confirm the absence of thrombus. The recruitment of the first-in-man study is over, and so forward, and the results should be available by the TCT this time. The study is going to confirm the usefulness of this promising device where it is produced.
Great. Galore session, and I'd like to invite
Can you cue my slides, please? This conference to Merrill. His blood pressure, he's in the department, and his physical exam is really fairly unremarkable. Lab staff. Can we play these all of these images continuous? All right. So, perform a significant chunk of our acute left universal guide catheter. We thought about using diagnostic catheters because there was diffuse ST segment depression. It was a little bit unclear what the culprit vessel was, although inferior ST elevations suggested that perhaps it was a dominant right coronary artery. And I think that you can see from this angio, so you can see the RCA filling. Second, in the left main, there is. It's playing perfectly on my one individually. Probably the picture that matters the most, and that still frame more or less shows it all. Fairly calcified Medina 111 that the distal RCA is filling from left-sided collaterals. So this is the RCA. The RCA is predicted is occluded in the mid-segment. It too has a heavy burden of calcium, the disease etc. here. So what's the next move? Place a balloon pump and phone your friendly neighborhood cardiovascular surgeon. Phone a friend. Probe the RCA Switch to femoral and attempt PCI of the circ from the radial approach where we supplemental medical therapy. We did a number of different things all at once. Just for grins, we probed the RCA, as you can see here, and it was, can we go back, please? And it was really quite so the slides are moving without me. We probe the RCA. Okay. The slides are just flipping without, I'm not clicking it up here. Right coronary artery. We tried a Fielder XT. We tried a CrossFit 100 XT. We tried a Miracle Brothers. At that point, we're going to stay and try to get the circ open if we can. As you saw on a previous the appearance of thromb. I want to go. We're not done with the previous. Yes, please. We're not done with the previous slide. Okay, play this, please. Go to the next, please. Go to the next, please. All right, so we crossed the circumflex with a PT2MS, a mid-circumflex. Go to the next, please. Here's where it starts to get a little bit interesting. So he starts to spiral pretty quickly. Yeah, we've got to stay on one slide. Please don't advance without. We got to go back. Okay, can we play that, please? Okay, so the original question quite well. Hemodynamics, chest pain. He became hypertensive briefly, and having a pulmonary. Please. You can see that he's struggling a little bit, so we went ahead and intubated him at this point. Next slide, please. We kind of skipped over all of that text. That text is sort of a key part of the presentation. Yeah. Okay, so
I would just, Sandeep, just keep going, and maybe we'll get your laptop if that helps you.
Yeah, that's okay. I mean, we can kind of talk our way through it.
Yeah.
The long and the short of it is that, this is sort of being broken down scene by scene, but the reality is that multiple things, pretty much everything that we had ballooned was now thrombosing, including the left main, and I think we could just play that first run. That first shot is really, really pretty telling, and so now we're at a slightly different, I'm not sure what's going on with this, but we're at a slightly different position now in place, and a stent up in the left main. And I guess the question for you, and Manish, I'd put it to you and the other folks on the panel and in the audience, what would you do next? We've got a balloon pump in that was quickly sort of thrown in while he was still hemodynamically stable, but he's quickly spiraled out of control at this point, and pretty much therapeutic ACT.
Available to you.
We do.
One femoral has the balloon pump in. The other femoral is available. So I think this is where and call the ECMO team in and quickly get ECMO, probably for an impella ecologic problem. This is you saw angiographically.
Yeah, and those are great points. In the meanwhile, I did call the surgeon before we wasn't expecting an actual answer from him. The answer I got was good luck. And so we did call the surgeon, and we pressed on. So go to the next shot, please. Next slide. So, one of the great advantages, I think, of working at my institution is that we have, as you have at your institution, all of these things that are listed here, plus some investigational devices. We have cross-trained our team to initiate ECMO in the cath lab. So we don't rely on our perfusion team or our surgeons anymore. For about the past 2.5 years, we've been putting in ECMO. A CardioHelp system has really gone a great way towards making us independent and autonomous in this regard. Go to the next shot, please, the next slide. So we already have a balloon pump in place. What are you going to do with this left main? We went ahead and quickly stented the left main into the wire, and our intention was for the left main. Next shot, next slide. Chest compressions with a Lucas device, and the last shot there kind of says it all, right? And got A and V act on the left. And we went ahead and we put him on ECMO. We put in a 17 French arterial cannula, 25 French venous cannula, quickly de-aired, clamped, and got him on pump. Once you are actually up and going in your lab and have get somebody on pump, so we were actually able to get him on pump in under 10 minutes. From the time that we got access, he was flowing at about 4 liters. And so the components of this system are shown here. The heart of this module that can operate on battery power for up to an hour and a half. We take a slide, please. The size of the cannula certainly matters. We chose the 17 French cannula here for the artery and 25 French venous cannula to try to optimize as much right-sided decompression, as much left-sided pressure as possible. And while he's in shock refractory VF on pump, he has a mean arterial pressure of about 70 to 72 millimeters of mercury, obviously with no pulsatility. Next slide, please. And so we've got the balloon pump in place. We've got him on pump. We've now gotten back to the issue of everything came out. So we had to essentially converted this into a left main culotte, still from a right radial approach. You'll recall we already had the circ stent in, and we had the left main stent in, jailing the LAD, and so now we're flex, of course, was recrossed, and there was a final kissing balloon inflation in the left main. 5 stents. Slide, please. And so immediately after this, he actually regained pulsatility and a perfusing rhythm, we left him on pump. The last picture essentially shows us panning down. You can see the multiple cannula that are in place. And the overall setup looks like you can see the pump, and so he was weaned pretty quickly. After about 4 days, we began to wean the ECMO or ECLS. We decannulated him in the OR after 6 days. No neurologic injury, despite about 10-15 minutes of chest compressions. Transition to patient. So it's this case just sort of illustrates all the things that can go wrong in the context of a infarct angioplasty, and certainly if this guy showed up with a non-STEMI, we would have gone in a completely different direction. But so much for your attention.
So it's an extraordinary case. I think it really shows and highlights what can be done with a team approach. We have a shock team like Sandeep does, and I think that unless you have ECMO and other support devices, there's no option for a patient like this to survive. Absolutely no option. And so, we've started a shock program, and it's worked out very well. And we are ready. Good afternoon.
Thank you, Manish. Manish, thank you very much. I was really fascinated listening to, I think it was a Dr. Nathan's case. And this is going to be fairly boring in front of his exciting bailout.
Good to have you, and we have about
I wish I could be there, and I'm interrupting the nightmares in the cath lab. Well, this is not going to be a nightmare. Come to you with, leave to you in your hands, and of course to many scaffolds in general, and just gets the hang of how we get the best to that. And the Absorb EVS itself is 155 microns. The other ones around the corner devices, apart from the MIRAS, which Merrill Life Sciences has innovated and invented to be a 100 micron device, which is quite credible and commendable. So the VVS as it stands now, and of course the most available commercially used device in more than 100 countries, and now FDA approved is the Absorb BVS itself, with the largest amount of data and large pivotal randomized trials in its favor. So, but it's not a stiff device. It's a plastic device, and you can actually see this right-angled LAD, that curve, pretty much a right-angled curve there with a 3.5. And so is this acute angled bend. And by that time, of course, the BVS is much softer, and these curves are expected to be maintained. So it's actually a fairly malleable device. It doesn't straighten out vessels, and it doesn't straighten out curves, which perhaps reflects some of the advantages of this device. Now, what are the types of cases? These represent usually what 10 to 20% of our patients are all about, because most of the patients fall into some real-world complexities like diffuse lung disease, calcified lesions, left main disease, and then you have understand that perhaps the best, but long lesions, bifurcations, automatic thought process, lesions. Why not? Therapy would actually may fall or bleed at any stage in their elderly lives. Absorbable implants, a plastic sandwich could certainly. Let's not get into the arguments of why not and why, but I must say that it's a thick strut device, and we need to take this forwards in the best possible manner as we in close to 1,400 patients, and a majority of the lesions have been complex and in a variety of settings. So let's say, what is the lesion selection, and what would I say you should not be doing? Well, heavily calcified lesions is perhaps not, I would say, not a no-no, because I do a fair number of heavily calcified lesions, but I think it still remains to be proven as to the benefits versus risk in this subgroup of patients. Excessive torturing, I've shown you that. It's a very diffuse with calcium diameter, and this to a 4.5. The maximum you can expand it is 4.2, so there's going to be an apprehension regarding stent apposition. Major bifurcations, this does not fall in my criteria as side branches in period of time, and one just needs to actually have learn the tips and tricks over a period of time. Or discoagulating stent restenosis, I agree, not much to choose in that. These are degenerating vein grafts, better treated by a metal stent till another lesion comes up. We all know that we got to inflate this device slowly, 2 atmospheres every 5 seconds, and I say that both for Absorb as well as in the first in-man study with the Mirus 100 as well, though I believe that it's more tolerant and we would perhaps do far better things once the device is approved. Certainly on the bench testing it behaves slightly differently and has certain advantages. So prolonged inflation over 30 seconds at a maximal pressures, so therefore it takes approximately 45 to a minute to implant this device. So here are my 7 mantras to achieving the best success with this device. And my 7 mantras go into good guide catheter support. Remember, generation of metallic drug-eluting stents, or for that matter, a first generation of metallic stents. And therefore, it needs good guiding, prefer 7 French for most lesions, unless it's a straightforward proximal vessel disease. You never know when you get caught at a curve where you need a better support. So catheter itself. Virtuosities, I would use an upfront buddy wire to deliver this device. It actually spares you the agony of withdrawing the device and then doing other things when you could actually deliver it upfront, provided you examine the lesion and the path up to the lesion far more carefully. So again, the same principles as just large ends, like the Cypher, for example, or like the Taxus. So these three, the 3, 4, 5, are perhaps the most important. And I actually say predilate the lesion with a shorter size, shorter length, non-compliant balloon, which is near optimal. And I don't go for an optimal, I must say. I believe that I create more dissections which extend upstream and downstream when I do it with an optimal size balloon. So I go with a quarter size, smaller balloon, 20 atmospheres, by which I know that I'm still within the realms of the vessel diameter and don't cause extensive dissections, but yet they have very little residual stenosis. So predilate, high pressure, shorter non-compliant balloon, 16 to 20 atmospheres till there's no waste, and that you can do by believing that what you angiographically see is slightly undersized by a quarter to a half millimeter, which is the normal case. You can do that by OCT, in which case you will get some optimal sizing of the vessel, and IVUS always overestimates the vessel to an extent. But you can also do that by a pre-dilatation balloon. So once you do that, once you dilate the vessel, you get an idea of the balloon as well as the vessel size. Size because the 0.5 millimeter higher than the device size itself. So a 3 can only go up to a 3.5 millimeters, and a 4 can actually go up to a 4.2 millimeters, though you have this 3.7 for a 3 millimeter. So keep that in mind, and you don't have a lot to play around with, size and the vessel size. Important mantras is number 5. I certainly believe in this post-dilatation with a non-compliant balloon, which is a quarter size higher than your visual or the scaffold that you've implanted, to 18 to 20 plus atmospheres, and yet staying within the expansion limits of the balloon. So 3 millimeter scaffold can be dilated with a 3.5 millimeter. Gets you to understand that what your angiographic what the vessel is, and that you really need to keep going a quarter or a half size higher in terms of your post-dilatation in many of these vessels, which you think are optimally sized. You need to use it in your 10 to 15%, 20s, and so on and so forth. Important point on the table results in scaffold thrombosis. These are attention to antiplatelet regimen. These patients should be pre-treated with clopidogrel prior to coming on the table. And if they're not pre-treated, then it is the new P2Y12 inhibitors while implanting multiple of these devices. And actually that for me would be at least a year of dual antiplatelet therapy at follow-up. And with multiple scaffolds and complex lesion subsets, including bifurcations, I would continue it even beyond. So prepare the lesion with a compliant balloon. Now I want you to understand that as you get these devices, this is here is, I hope you can see this clearly, is a stenosis which is high grade in an OM on a right angled takeoff of a circumflex which has 2 curves on it, and there's some calcification. After having done a pre-dilatation of this lesion with a 2.5 at 20 atmospheres, what I want you to note in this is this here an all-star wire will gradually take this down, as is seen in this image here. It gradually pushes it down without doitering. Be patient, sustain push, and then it gradually comes down into position, and here it is implanted, giving a good result. So you can actually get these devices down, but you've got to be patient. With a vessel, you can actually be talking about 2.7 to a 3.3. Assess a vessel angiographically to be a 3, then you can be sure it's a 3.25 to a 3.5. So I would, if I was sure that it was a 3.25, I would implant a 3.5 scaffold and go up with a 3.5 at high pressures. If it was a 3, I'd take it up at 3.25, take it up, and maybe even a 3.5 balloon to a high pressures. Well, this is almost like 20 years ago, deja vu. High pressure DIL is what we learned 20 years ago when, and this is no different to that. It's back to the basics. This is how we should do things. In this editorial where I demonstrated that you have this 2.5 millimeter balloon atmospheres, the pre-dilatation is adequate, as you can actually see in this view here. 5 into 28 BVS deployed at 9 to the implantation balloon itself. But what we see different on the implantation had malapose struts. These struts are now well opposed, even though the final balloon size was very, which have increased to 5.74 million. Here you see nearly a third embedded scaffold into a supply atmospheres. And that may actually help you to understand that you may not need DIL as needed, because if you post-dilate all at high pressures with my philosophy, then you only end up imaging a few because you actually have achieved the final results. How much time more do I have, Manish?
No, you keep going. You have another few minutes. You're doing, this has been very useful.
Not here is this PDA, but the PDA and across the way. Even though the disc wire up front into the small PDA, and that PDA is no more than a 2.25 visually, which makes me feel that it's a 22 at scaffold down. This is a marker to marker overlap, and I'm going to tell you implant. But I want to also show you this. When I've taken one of the wires out and I'm implanting this proximal device, look at the fact that I do have a problem getting this device across this slight calcified bend, which was easy when I had a buddy wire. But then I finally get these scaffolds down, and after 5 scaffolds and 13 centimeters of a coverage, dilated up from 2.5 at high pressures to 4 millimeters at high pressures, we actually have what looks like a neat, very good vessel, 30. But what is interesting is that a 3-year follow-up, slightly larger, vessel looks enlarged. And this is why I would say that this is endoluminal reconstruction. By this time, scaffolds would have disappeared, and I believe that that's why I believe that this absolute metallic jacket increasingly every year with a full over the distal scaffold marker like this. And when we do this, we get a millimeter of an overlap, or less than a millimeter overlap. But in smaller vessels, I would now bring this marker, I would bring this marker now to not on the distal scaffold marker, but just before the distal scaffold marker. If I bring it just before the distal scaffold marker, then I would actually have edge-to-edge overlap, because if you understand 150 micron overlap, even if it is a millimeter, actually means 600 microns, 0.6. Okay, just a bit of word about bifurcations. One of my favorites, I must say, as a metal device, provisional strategy in most instances, though occasionally we take the side branch, the FME3 flow. Of course, if there's significant pinching of the side branch, one can open the struts slowly, again, 2 atmospheres every 5 minutes with a 2 or a 2.5 millimeter balloon with a sequential graduation without disrupting the device, and do what we call a fine. I want to tell you that this was the technique that we first described ever when we first described the first ever case reports of a 2-scaffold strategy using tap technique, and we described this snuggle technique. The snuggle balloon dilatation is what this is, where you actually do not keep protruding to a snuggle rather than the vicious voracious through the struts of the device. At a scaffold, then you can actually scaffold up to 10 atmospheres, which is the safe threshold. Beyond this, there's going to be device disruption. But if we have a snuggle, a balloon, but a 3 millimeter balloon should only be taken to 5 atmospheres, otherwise there'd be risk of disruption. As we define them, and we've now got 2 scaffold strategies, and you'll soon see it in the press, in the publication, 2 scaffold strategies, scaffold in this large OM, and we see that the side branch, which is the AB group circum, as a branch scaffold into. This was one of our first cases, but a 3-year of this micro tap technique. This is. Let me just get to. Anyway, I'm going to take this before I come to my conclusion. It has instance, as you can see here, LAD being rotablated, diagonal being rotablated. Following LAD, we can actually now get the scaffold after with again inflated. Proximal part of it was inflated with the 3. Next set of slides, dilate the side branch of the main branch scaffold and pass a 2.5 into 8 millimeter scaffold through the side branch. And you can see that beautifully coming through. It goes easily and smoothly through most instances on these side branch scaffolds with the marker of and the marker of the scaffold is at the less than a 1 millimeter carina being actually inflate the balloon, what we see as a final result. The distal diagonal was not diagonal. So here is a scaffold, not just going through the main branch scaffold, through 2 struts. And this is what you see now, quite neat looking artery, which was earlier badly. They show a nice microcarina, which I won't waste your time on, but you can see it here, good apposition, opening of the side branch here. RCA was also scaffolded by a 3.5 into 18, dilated to 4. This patient matrix. It's an innovative device with open cells at the center, closed cells at the edges. Very fascinating. It's there, and we have a complete advantages here. Bringing in such innovative technology, and you're lucky to be an investigator of the MIRAS 100 device, the 108. Thank all the investigators for having contributed complications of thrombosis of this device. These are the enrollers into this MIRAS 1 study, and I thank them for actually having been so sincere about this effort. Data by September to let's hope that is like a first generation metallic stent, is therefore back to the basics of good deployment, good optimal deployment technique to your antiplatelet regimen and anticoagulation regimen, and it requires tricks for complex lesion anatomy to have a successful results similar to the best-in-class metallic drug-eluting stents. Thank you very much for your attention.
They've only 12 sites. The one thing that strikes markers are very, very challenging to see. At least this becomes much more material. What are the tips and tricks you can share with us about that? Because this technology I find very challenging.
And when you end up, quite clear that stent boost does show these up very well. So you to use stent boost regularly for these devices.
Okay.
Must also, there's only one marker. Well, there are two markers, but they're only one side.
Right.
And therefore, you might actually, you actually have to turn your camera to another direction so that you can actually see it on the side, because sometimes it just starts overlapping. See it if it's in a profile rather than on, because it's a single marker. So you actually have to be very sure that you're actually perpendicular to the device, otherwise you can be beyond the marker with your balloon or even miss the marker or be before the marker. It's a good idea to see it in two directions to be sure that you're actually above. If you've expanded, those markers are so clear, and because even though you don't see the scaffold. So I think that we certainly, the next generation would actually have better markers, or at least two markers. I'm only telling you one more thing, that most of the companies, even the imaging, the cath lab companies are coming out with softwares which would make us more easy to see these devices.
Yes, go ahead. Yes.
First generation BBS. So this trial will affect future stent thrombosis as compared to previous first generation BBS.
It's going to translate to lower stent thrombosis.
Yeah, I think that's why the thin strut devices came later. And the thick struts do endothelialize later as compared to thin strut devices. I do believe that could be one of the ways to look at the advantages of 100 micron BVS. So I'm at some limitations as in real life about losing the radial strength. After all, no question, these are plastic devices, and even though on bench testing and in vitro demonstrate them to be microns and sometimes even the 150, to have the principles correct of doing what is, especially as we go on to more complex, allow us to do even more challenging lesion subsets more easily. But I don't think we will give up the tips and tricks.
That was very clear. Appreciate the time you spent this afternoon with us. Have a good afternoon.
Thank you, Manish, and I look forward to seeing you tomorrow in Delhi. I think you're
Yes.
going to be in Delhi tomorrow, day after.
Yes,
Look forward to seeing you there.
Absolutely.
All we know is that CTO did with higher risk of many operators why they stop procedure. Perforation occurs, definitely exercise. After that was done coronary angio, where we found diffuse atherosclerosis and right coronary artery is diffuse atherosclerosis, and right coronary artery is osteally occluded. Because I didn't see stump and osteum of right, I decided to start this case with primary through first septal, and on the image collateral crossing with cyan wire. Collateral crossing was not difficult. I did it within 1 minute with Corsair microcut. After that, I advanced my Corsair microcatheter. I crossed this occlusion retrogradely, but suddenly I felt that I'm losing my wire support, and when I looked more, loop have become together with wire slip back. After 20-30 seconds, microcatheter together with wire slip more back, created a loop and prolapsed to the left ventricle. Patient at this moment had discomfort and palpitation due to ventricular extrasystolia. After that, I removed my corsine microcatheter. I did coronary angio, and I saw that here is septal perforation. Immediately was done normal. What next? Stop procedure. Continue. If we continue with retrograde approach, antegrade approach, because the case was not done, patient was stable. Radiation at this moment was near 1 gray. Echo was normal. I decided to continue this procedure with retrograde approach. I tried to cross other septals, but it was not with Gaia third wire. This is final result after 2 drug-eluting stent implantation and septal perforation, as we see, still exists. Patient was discharged next day with normal echo and with no complaints. And this is 1 month follow-up with perforation disappeared. Septal collateral perforation occurs with guide wire manipulation, occurs when microcatheter is advanced over an external very small tortuous septal collateral. Create perforation need specific.
I wonder on echo. No. Yeah, about 10 years ago, a pretty large septal hematoma. Thank you so much for that. Any septal perforators also that there's such a to be small, but in the one case that I've seen, pressors. Other questions, Dr. To Merrill, of course, for putting on. Thank you so much.
At the same, we are also going to start at 9:30. Peripheral intervention. For any questions or queries